Know that he is somewhat of a genius and somewhat looks like George Clooney, but Dr. Joseph, come on up.
Just gave you the 20, so we're good. All right. Good afternoon. I did not realize I was going to be speaking after lunch, so I have to jump around and be crazy to kind of keep you guys here. We're going to talk about human-centered design and why that's important and how you can leverage these very basic principles in all the work that you do. Whether it's tech, I'll be talking a lot about tech, but I'll be talking about other things as well that are healthcare related and how we can learn from other industries and how they've done things. As David mentioned, I co-wrote a book about applying the principles of user-centered design to healthcare, and we'll be signing those. They're regularly, we'll just give them away, but if you wanted to make a donation to me of $100, that will be fabulous for my children's college funds. These are essentially some of the chapters in the book. So we'll start just kind of going right through this from make it easy to do the right thing to finally continuously improving. I like to have interaction with you all, so I will be asking questions from time to time to make sure that you're awake, and feel free to respond. Also, feel free to stop me if you have questions. If we can make it work so that we don't have to do all the questions at the end, I'm happy with that. So let's get started. Again, I mentioned this is from, essentially, this is what you're going to get in that book that you might want to give me $100 for. Why is everyone laughing? Okay. So just a reminder from someone you probably know about his definition of design. I'd like to ask, actually, before we begin, are there any designers in the room? Anyone who's a designer? Well, if you believe what Steve Jobs thinks, and design is really how things come together, how they function, let me ask the question a little differently. Has anyone implemented a technology like an electronic health record at a hospital? Has anyone been involved in figuring out how clinicians or billers are going to get their jobs done by figuring out the workflow or what the form should look like or what information should be there? Yeah, so you're getting where I'm going. You're picking up what I'm putting down. You all are designers. We're all designers, whether you want to be or not, whether you have any formal training, whether you thought about that or not. If you've done any of those things, if you've tried to figure out how stuff's going to work, you're a designer. And the question is, are you applying some of the principles of design that professionals have figured out to the design work that you're doing, whether you want to do it or not? And I'll tell you right now, one of the pleas, if you walk away from this talk, is that if you have professional designers, human factor engineers, if you have those kinds of folks at your hospitals, I can almost tell you for sure that they're being ignored. Hopefully not by you, but by some others. And so trying to find those people, let them do their work, and I'll give you some real-world ideas as to why that's the case. So let's start with the first of the 6 principles. Make it easy to do the right thing. Seems straightforward. Why would you not do that? Yet, if we think about the way the EHR is designed, or pretty much any workflows for clinicians or patients, oftentimes it doesn't look like we've made it easy to do the right thing. And I get pushback from time to time. Hey, you know, how was I supposed to know that they weren't whoever they are, nurses, doctors, front office desk, staff, patients, your CEO? How did I not know they were going to respond that way, the way I thought they were going to? They did the opposite. Well, I'm here to tell you that humans think and behave in a predictable pattern. Is it always a logical pattern? I wish. No. But they do react to things in a predictable way, and as long as we understand some of those, we can really leverage some of those ideas into how we design things and make things work. A key principle to understand is choice architecture. Has anyone read this book or heard of this book? A few of you. This is really a seminal work from Thaler and Sunstein, behavioral economics professionals and academicians, and basically they came up with this idea of choice architecture. And what does that mean? It means essentially, the way you ask a question predicts the kind of answer that you're going to get. And so it really matters how you frame that question in order to predict the answer that you're going to receive. Sometimes if you ask the question in a certain way, you'll get the opposite. So how does some of this work? I like to look outside of healthcare. So here are some behavioral economics academicians decided to find very good and easy and cheap lab rats. We call them college students. And in this study, they wanted to see if they could get students to eat better. And again, think about the way that this cafeteria, cafeterias at least used to work, is once you got in, you could take as much food as you wanted, you could go up as many times as you wanted. So it was pretty much free for all. And they had healthy food and they had not healthy food. And they wanted to see if they could get students to eat some more healthy food. Some of the things that they tried that were successful, it's actually kind of crazy to think about it. The first thing they did is they made the trays, the trays that you put the plates on, smaller. Trays were just smaller. Could only fit so many plates on your cafeteria tray. And so what did that mean? Well, you could, again, go up as many times as you wanted, but once you had started eating, they found that, hey, they were not as likely to go back and get another helping because they weren't hungry, right? Because they were eating slowly. They found the size of the plate. So not only the tray, but if we gave you smaller portions, fewer servings, again, you could go up and get as many servings as you want. You could take as many servings as you want as long as you could hold on to that. It was kind of interesting. So again, some of the other things that they did, and this is kind of crazy, they put a sticker with a smiley face on healthy options. And I know you're thinking, oh, well, and then they had a poster where they explained what a happy smiley face meant, or they did other kind of educational outreaches. Nope. They just put a sticker with a smiley face on certain things. Others, they were more obvious. This is good food. Eat this. This is good for you. Okay, that was effective. Another thing that they did is make it more pleasant to look at some of the food. So they took some of the fruit, and instead of just kind of throwing it on a plate, they presented it in a nice and appealing way. And this increased significantly the likelihood that college students would eat healthy foods. In fact, by doing just some of these things, and again, nothing major, just changing some sizes of plates or trays or putting a sticker on a food, 2.5 times they were more likely, the students were more likely to eat, to improve their diet. Again, with no interaction, no training, no kind of lecturing, it just kind of worked. This is the easiest question you're going to get asked today, which is bigger, 49 or 86, and I'll tell you why I'm asking this question. Again, with choice architecture at the base. This was a company that did a study. They wanted to increase the percentage of their new employees who signed up for their 401k. They were trying to encourage retirement savings. That's a good thing. And when they started, about half of their employees signed up for the 401k. And then they did this one intervention, one simple intervention, and they went to 86%. Who knows what that intervention is or can guess? What was it? No, they'd already done that. And so they had already had a match. They had already tried to educate all these new employees about about the benefits of putting away for finances. Yes? Auto-enrollment. Auto-enrollment. They changed the default. The default was you have to ask to sign up for the 401k. They changed the default to you have to ask not to sign up for the 401k. And they went from 49% to 86%. That's choice architecture. Changing the way we ask the question can change the answer. Most people had intended to sign up for the 401k, just never got around to it, forgot about it. When it made it easy to do the right thing, went to 86%. So this is not just kind of, as I've been trying to show you, those were two academic articles. Here are some more. This is from JAMA. Here's one from the famous academic journal called the Harvard Business Review. how to get surgeons to make more cost-effective decisions, and they put a little prepositional phrase in there, without jeopardizing care. And here's a final one from Jamie, and I'm going to go into this one into a little bit more detail, talking about nudges. And that's one of the key concepts of choice architecture, nudging people, setting defaults, making it easy to do the right thing. So this one article is from UCSF, and what they found at UCSF is that some doctors, a lot of their clinicians were making bad decisions about certain things. They weren't killing anyone, but they were suboptimal decisions. The first suboptimal decision was a Dilantin level. Dilantin's an anti-epileptic drug. We have to follow it very closely to make sure that you're in a therapeutic range. It's easy to go too high or too low, so we're always drawing blood to make sure that you're getting the right amount. People were ordering a free phenytoin, meaning a part of the phenytoin that was more available, as opposed to total phenytoin, total Dilantin. And you might say, well, what's the big deal? Well, the big deal is one costs a lot more, and it takes a lot longer to come back. So I just wanted to get some idea of where the patient was with their Dilantin level, make sure if I needed to make any changes. And I wasn't getting that answer for 2 or 3 or 4 days. And I didn't know why, and it made people a little angry and wasn't optimal care. The second thing they noticed is that physicians were ordering a CT of the abdomen very often, when actually they needed a CT of the abdomen and pelvis to solve the problem. So they got the CT, they got what they ordered, and then they said, oh, this doesn't show me low enough, I can't really rule out the problem that I'm trying to rule out. Then the patient had to go back for the CT of the abdomen. And the final thing that they noticed that they wanted to work on was overdosing of benzodiazepines like Valium. So imagine that your patient's coming to get a study like a CT. Oftentimes people are a little nervous about going to that tube. Hey, we'll get you a prescription for Valium. It's pretty easy, straightforward. It'll just take the edge off. That's fine. But what they were doing accidentally is ordering what was defaulted in to the system, the first thing that they saw, which was 60. We're going to order 60 of these pills. You can imagine that turned out to be a bad idea to give patients that. So they wanted to work on this. How would you traditionally do this? Well, you would go to grand rounds, you would go to physician meetings, you would give them continuing medical education to explain to them how they're supposed to be doing their job more effectively. That's one option, and you should consider doing that. But what they did was look for, hey, can we use choice architecture? Can we use the technology that's out there? And they happen to use Epic. If any Epic colleagues of mine are here, these are all screenshots from the article. There's no intellectual property being stolen. I just want to say that before I get arrested. So what did they do? For the first problem, this is the problem where people were ordering free phenytoin when in fact they probably just needed a total phenytoin, is that when they typed in the word phenytoin into order entry, they didn't see what they wanted, right? They got a different choice. And this choice was like a little mini order set. It had 2 orders in it. And I want you to see if you can read what it says. I'll read it to you. Please note, I have to get close. The most appropriate order for phenytoin level is almost always phenytoin total. Please only order phenytoin free if you have consulted neurology and if they've recommended that, right? So that's pretty helpful. That's information that I need at the time that I need it. But it's small print, might often go overlooked. They did another thing, and we learned about that from what that 401k example was. They defaulted in total. So you could type in free phenytoin if you wanted to. You're still going to get this little mini order set, and the total phenytoin's already clicked for you. So what did you have to do? Did you have to call someone to get permission? No. You just had to unclick the one you didn't want and then click the other one. Very simple. It takes 2 seconds. No one does it. No one does it. Just like that 401k. Almost no one says, no, I don't want this. Most people want it. So that was a pretty simple fix. What should you do about the CT scans? Remember, people were ordering CT abdomen when they probably wanted CT abdomen and pelvis. What did UCSF do to fix this? They added a space, if you can see it. They added a space in the one on the right. They added a space after the slash, which then changed the order and put CT abdomen just by itself below CT abdomen and pelvis. And what happened? Significantly more physicians ordered the first thing that they saw, which is in fact what they probably needed, which was a CT abdomen and pelvis. Pretty easy fix. But if I'm an expert and I know I just want the abdomen, can I get that? Yeah, it's right there. Just got to click down. In fact, it's the same number of clicks, but I have to think now. I have to aim down to the fourth one instead of clicking on the first thing that I saw. And then finally, the question of, hey, what happens when I'm trying to order a couple of Valium and the default that pops up is 60 days or 60 pills with a bunch of instructions that say take as needed, when in fact I needed just a small amount. They added another order, what at least seemed to be to the patients, to the physicians, as another order. And it's got the words in it, as you can see, imaging/procedure. So now I know, well, if I want it just to be configured perfectly, I can just click that, or I can just type in diazepam or whatever. I can type in the first three letters of the med and then hit a space and then type in IMA for imaging, and I'm going to get this order already configured for me. So pretty straightforward, pretty easy. And again, all of this is associated with data that showed that by changing the way the question was asked, by changing the format just a little bit, physicians you make it easy to do the right thing, you give them the information that they need. And whenever I'm working with clients, they're always like, hey, we're going to do innovation. We're going to find this third party that's making the software that's going to make it easier for our doctors to do the right thing. And again, sometimes it's just saving money. And I think that's great. This is cheaper, and it's faster, and it's often effective. And so using this in your armamentarium is very helpful, kind of understanding. So I thought I'd make a fancy graph for you to understand how you implement, make it easy to do the right thing. And I promise you I've worked with, gosh, probably 100 different clients around the U.S., and making it easy to do the right thing is super simple. What is the hard part? Step one. Figuring out what the right thing is. That's the hard part, right? Because there's always going to be some physician who's going to say, but I do need to order a free Dilantin, a free phenytoin. Okay, well that doesn't mean that you represent everyone. You're a 1%, and we're going to configure this for the 99%. So often the hardest thing is just to figure out what it is you're trying to get folks to do. The easy part is getting them to do it. What are some specific examples of making it easy to do the right thing? I threw them in here, simplifying your choices, adding a default choice, right? See that very often. We make an order set in whatever EHR we're using, or there's a form that someone has to fill out, and we know that 80% of the time they're going to, whoever they are, whatever they're filling out, it should be this choice. But then we wonder why people don't fill out that choice. Fill it out for them. That's the recommendation, if you can. Obviously, we don't want a safety event, and I've just told you that most people, most of the time, will just go with the default choice. So it has to be the right choice most of the time. But that's really the way to go to kind of make it work. A specific example that someone did was opting out for a home visit. Hey, do you want a home visit? I don't know. Yeah, I guess. If I have to ask you, I'm going to get a smaller percentage of those patients than if I just say, hey, we're arranging for a home visit. Any reason why we shouldn't do that for you? It's an easier way to ask the same question. It has nothing to do with technology. It has to do with understanding how people think. Giving immediate rewards. This works with two groups. One is dogs, two is humans. I'm not saying one's better than the other. I'm not saying that either. Giving immediate rewards. Hey, you just signed up for this thing, or hey, this was the 100th day that you recorded your weight and sent it to us, or stood on the scale so that it could automatically be sent to us. Little kinds of incentives like that can make a big difference. Putting a sticky note with a smiley face on a computer that's been cleared of the blue screen of death software is another easy way to kind of help people figure out that the thing is working that they need. And so again, I would say that example that we heard about right before lunch that's design. Whoever did that might not have thought it was design, but that's design. So you should up that person's that analyst's salary for their designer just a little bit. All right, that's fine. Some of the other things you can do for just making things a little bit easier to do, again, framing things. You'd be shocked. I was shocked when I saw this example, the first one that we talked about. The difference between telling people they need a flu shot to stay healthy versus telling them they need a flu shot to avoid illness. One is positive and makes me have good feelings. Staying healthy, I like that. Avoiding illness, well, I generally want to do that, but it sounds a little darker. And so doing kind of experiments, doing A/B tests where we change the language a little bit and see a big difference. Providing social proof. I know this happens whenever I book an airline ticket. It always tells me when I scroll down to the insurance that they want me to buy. It tells me how many people in the last 30 days have bought insurance, travel insurance. I still say no to Delta. Any Delta representatives here, I'm not buying your insurance, but hey, if everyone else is doing it, this might be something that I want to do. So, you know, some of the ideas of leveraging design. All right, so that was making it easy to do the right thing. The next topic is gross, or getting rid of stupid stuff. True story, when I co-wrote this book and we had lawyers from my company look at it, and the lawyer came back and said, you have to change the title of this chapter. And I said, why? Stupid that's an okay word. They're like, well, you're implying that our customers might be doing stupid things. And I said, yes. I'm implying that they're doing stupid things. I'm implying that I'm doing stupid things. I'm implying that we all do stupid things fairly often. And that was not, they didn't like it all that much. It was a little bit better, and this is from, if you haven't seen this TV series, David. It was a little bit better when I pointed out that, hey, this was not my term, this getting rid of stupid stuff. I mean, it's a pretty common term, but it's actually a famous New England Journal of Medicine article from the Chief Medical Information Officer at Hawaii Pacific Health. And she did this insane, crazy thing. Many of us have done part one of what she did, but most of us don't do part two. Part one was she went around the hospital asking employees who used her electronic health record what stupid stuff was in there. What's in here that doesn't make any sense, that we should get rid of, that we should reconfigure or rethink. That was the part that I think a lot of us do. The crazy part was part two. She then fixed stuff. She was very transparent and went back to everyone who said something and either A, fixed the problem, or B, educated that person as to why that problem could not be fixed. So sometimes it seems stupid, but in fact there was a real regulatory reason why it can't happen. Or it seems stupid and the fix is very expensive and out of the reach right now for our budget. Right? By keeping that, asking people for feedback and then acting on that feedback, or at least being very transparent about it, was essential. And she got a lot of acclaim for this short little article. And when I look at it, I was like, well, I could have done that. The difference is that she did it. So what are some of the things that you can do to kind of get rid of stupid stuff? Well, get rid of clutter. Get rid of clutter on your website. Get rid of clutter on the forms. Get rid of anything that seems superfluous. I'll give you one example. Ask me to give you my past medical history and other financial information so that I don't have to do it when I get to your clinic or your hospital. And then when I get to your clinic or your hospital, act like you never knew that I sent that to you already and ask me to give it again. I love that, and I'm sure your patients love that. And I see a lot of heads nodding, right? Because we know we do that. Or this office, this clinic is working with us, but this clinic prefers this other form that's 98% the same, but 2% different, so it's incredibly impossible to use that form, right? These are the kinds of things that make people nuts, and you don't want to do them if you can. Let's see, what other things that we can do to kind of get rid of stupid stuff? And this, again, is this a design principle I'm talking about? Yeah. Is it a highfalutin design principle you need to go to D school for? No. If it looks like it's not needed, then try to get rid of it. Can a post-op visit be done via telehealth instead of coming in? Well, I never really thought about it before. Well, but I'm not going to get credit. I'm not going to get an RVU. All of these are reasons that can be overcome if you just think about it. And one of the best ways of challenging these ideas is to ask people why a lot. Leishi. That's not the way it works. for the audience, she said she's going to pick on me because I'm a physician.
In my career, I have found quite a few stupid stuff.
Yeah.
That was because as physicians know this, we have to do it.
Yeah.
We know it's stupid.
Yeah.
He said, like my favorite was, they were printing out something from Epic and scanning it back into
Yeah. That's. Yeah.
and also when you said, because this clinic wants it this one special way.
Yeah.
Someone in power, who had the authority to make that decision.
Well, I gave David a 20 before he introduced me. It's right there. I want it back, by the way. It was all for show. I'll give you another 20. Yeah, so two things. One is, well, if a physician says it, it's right. So let's just, who's with me? Who's with me? All right. I lost the crowd because of you. I will address that. I have a slide that perfectly addresses your point about identifying the appropriate end users for us to talk to when we're implementing technology, and it's often not the physician in charge of something. So that's an excellent point, and the only way you kind of get around those powerful people is to approach them with logic, and then when that doesn't work, to go over their head, right? And so I think a lot of us who've been in kind of positions of leadership at healthcare systems, I know that this was true for me, and we were kind of talking about it a little earlier. I had a deal, I was the CMIO at a big hospital system, and the CIO said to me, I can never be surprised. I need to know about these things. I need to know about whatever it is that's controversial, because they're going to get me at the elevator that goes up to the C-suite. And that these people, physicians often, department chairs, will sit there and wait for me in hiding and then jump at me, and I need to have the answer, right? So preparing your leaders to understand that, hey, this guy's going to complain about this thing. We feel we've addressed it. He's going to tell you this. Let me explain to you the rest of the story and the context, and we can often work around that. Sometimes we have to do stupid things to prove that they're stupid, and I'm fine with that. When I say, oh, we're going to do this thing. Hey, we want to do this thing for this one surgeon who brings in $3 million a year himself. And we want to give him this thing that no one else has but everyone else wants. And I would go around saying that's probably a bad idea. And they're like, well, okay, we're going to do it anyway. And my answer has always been to leaders, and we're getting off the design, but my answer has always been, I'm fine to do it. When other doctors ask me why they can't have it, I'm sending them to you. Because I'm not going to lie to them and tell them that I thought it was a good idea. And so as long as the leader who's telling me I got to do this thing that's dumb is fine with explaining it to other people, we're all good. Now, to get to your point, start with the end user in mind. And who is this end user? Well, you might think that the Homo economicus, this is what economists often use as, this is the logical, rational human who does only things that are in that person's best interest. So it's good for me and my family, but it's not good for the community. I'm going to do that. That's how they think. Unfortunately, that's the person that we want to have, but that's not who we end up with. We end up with a very upset person, a very upset clinician or operations folk who's kind of getting rained on by people who are making other decisions. So we're not logical, and we don't think logically. And so that's important when we're implementing a new technology or a new workflow, that we get the right person at the right time. Step one of understanding this and aggressively finding the right person is that I'm going to tell you all something, and I'm hoping most of you are sitting down. That's good. Healthcare is broken in the United States. Most of us don't understand it, and we're the ones that are working in it. And so trying to kind of engage, getting folks to engage in healthcare, if you don't acknowledge at the beginning that a lot of this doesn't make any sense and we really need to go out of our way to explain why it is, you're going to be in trouble. So acknowledging the real world, especially when you're getting end users to try to figure out how we're going to configure this EHR, how we're going to create this new workflow for patients, acknowledging that it's really an ugly world. Sometimes we're asking people to do stupid things, And we need to kind of say that, yeah, this doesn't make a lot of sense. Here's why we need it. Let me give you that information. Often context keeps helping. But really kind of keeping your eyes on the prize of what is the end goal. And as Lacey mentioned, oftentimes people have a different opinion about what that end goal is. So understanding who you're creating something for. If you say, well, we're creating this for physicians, well, that's awesome. What kind of physician? Is it for all physicians, or is it just for primary care? Or is it for that cardiologist? It was a cardiologist, right? Neurosurgeon? She doesn't want to say. She doesn't want to say. That's fine. Protect the guilty. Oh, we're doing this for nurses. Okay, is it a registered nurse in the ICU? Is it a nurse in the clinic? Is it a medical assistant? They all are going to come with different ideas about how this thing should work, how they interact, how they do their job, and you need to know. And one of the best ways of knowing, of meeting users where they're at, is to ask them. A better way is to see what they do and how they do it, right? Management by walking around was, I think Jack Welch is the first one to come up with it. I just call it rounding. You know, walking around and asking people, that's super helpful. Like, hey, we're going to do this thing. Does that sound like a good thing to do? What's even better? Just being quiet and just watching. It's the most amazing thing, and I think any of the CIOs or IT leaders in this room, you've probably done this, and then seen the most horrific, horrible, awesomely bad things that you had no clue was even possible to do. I personally, I'm a little bit sarcastic if you haven't noticed that, I personally, when I worked for a big EHR vendor, who shall not be named, but is based in Wisconsin, I'm not naming them. I personally told at a go live physician who I watched do something. Was she admitting a patient? I don't remember what it was, but I told her, like, if you paid me money to come up with the worst possible way of getting this thing done, I wouldn't have come up with anything nearly as bad as what you just did, right? It's true. Like, if you would have asked me, like, well, I guess they could have gone over here. Or they could. She did the most backwards thing it was possible to do to still get the job done. And if you asked her, how's everything working out, you know what her answer would have been? Fine. It's fine. Because she had developed muscle memory, and it was working for her. And the 20 clicks that she did were completely fine for her. For me, I wanted to jump out the window. So you see these things when you're walking around, and that helps you to design better, right? How can I get the message out better? How can I make it more obvious? How can I make it easier to do the right thing and slightly more difficult, but not impossible to do the wrong thing? And you learn a ton by doing that. Getting on to the next principle, adding transparency and predictability. These seem straightforward, but they're often not. I love taking pictures of elevator buttons. So you're gonna see some, and hopefully you'll start taking your own pictures of things that don't make any sense. There are two things that if you ever see one of my presentations, will be elevator buttons and doors. Love me some doors. And rule of thumb is if a door needs an instruction set as to how to use the door, it's a poorly designed door. If it says pull or push, I should not need those instructions. And if it gives me even more, yeah. So what's the point here? There's only one button that about 99.99% of us are ever going to push. Where is it? It's not at the middle. It's at the bottom. It should be at the top, and all these other things that no one... How often is the fire chief going to need to come to this? I'm not saying never, but I'm saying almost never. Hopefully never. That should be at the bottom, and it should be small, and it should be kind of hidden so that I don't go to... I go and I regularly press, and I regularly press the key at the top for the firefighters. 100% of the time I go and I press the key. This is not a good idea. And we do this in our technology, and we do this in our things that are not technology, and we wonder, why are people upset with us? So, which do you think is better? Why is one? I like one of these a lot more than the other. It's pretty obvious probably which one I like. Which one do you think? Just shout out which one's better and why. The one on the left or the one on the right? The right. Why is the right better? It's doing something. Well, there's this, which floor do you want to go to on the right? Like, I can see from a light, it's telling me what floor, when I press it, that I'm going to go to. So I already know that 6 or whatever floor is lit up. And on the left, 4 people can come in. So in this case, it's 2. But a bunch of people can come in and press the buttons on the left, and they have no idea. Did it work? Do I need to press it harder? Did the guy before me already press it? No clue. So that's adding some transparency. I already have a mental model about how an elevator works. When I see that light, I know that that's already helped me. So I think one of the key messages is when we talk about design, in this instance, so human-centered design, we're really not talking about interior design, where, well, I like modern and sleek, and this other person likes more classical, traditional, decor. And no one's right, no one's wrong, everyone has their own opinion. Not about this stuff, right? There's no real opinions for most of this. Like, we know what's going to be effective. We know what's likely to make someone push on a button or sign up for a 401k. And there's really no argument about it. The argument is no one thinks about it, no one's intentional about it. So there are ideal designs. And again, thinking about transparency, I need to understand how the thing works so I have an idea about what I'm supposed to do next. Giving me this long, drawn-out instruction, giving me lots of information when I really just need to know 1 fact or 2 facts is very unhelpful. And I don't know if any of you have had to go and work with a designer for your house or for something like that, and they give you 14 choices. And I know that I'm just like a deer in headlights. It's much easier when they give me 2. And I can go, yeah, I like this one more than that one. Great, that's much better. Doing some of those kinds of things in the work that you do is helpful, will be helpful to you, will be helpful to the patients. This was an elevator I was in. I was trying to get to the ground floor so I could walk out. There's 3, 2, -1, and -2. I still don't know what I did, but this was in a different country. We generally don't have negative floors in the U.S., but still, I liked it. Being predictable is very important. And so something transparent is helpful, being predictable so I know what I'm going to get when I get there. What's really not makes me happy is when I go to my first clinic at your hospital, and they've leveraged all the tools, and I've filled out all my stuff on the patient portal, and they're just like, hey, you did a great job, go sit down. And then I go a week later, and it has the same logo on the door to a different clinic, and they're like, we have no idea what you're talking about. We've never seen that. Here's the paperwork. Please go fill it out. Okay, but I didn't put in a lot of time buffer, so now everything's going to be late because I assumed that I was going to have the same experience I had at the last clinic, which had the same logo as this clinic. That takes away predictability. It's bad. So there is, we say in medicine, or at least I say, standardization is the S word. You want to avoid that word when you're talking to those problemsome and troubling physicians. But standardization helps move to predictability. Predictability makes a usable, user-centric system. So think about it. If any of you go to Madison, Wisconsin, for any reason, one of the hotels that a lot of people stay at who go to conferences at that EHR vendor that I mentioned, they stay in this hotel. This is a hotel that I stay at all the time. There are three elevators right next to each other, 3 elevators in parallel. And do you see a difference between 2 of the elevators here? They look almost identical, don't they? Yeah, one's a little different. The one on the right, the one on the right has a 4th floor button. The one on the left does not. Now, why is that? Yeah, it's a service. That's where all the mechanicals are, and you can't get there. You have to need a special Prox card to be able to press the 4. But by making this different, for frequent travelers such as myself, when I'm staying on the 9th floor, I get used to going on the left, down 1, click. And the reason I discovered this is because I got into an elevator, I went down the left, 1 click, and I went to the wrong floor, right? They're taking away my ability to create muscle memory. This is a minor issue. However, this is the kinds of things that you and I do all the time with our customers, our patients, and this is something that you want to avoid and kind of think about. So yeah, don't do that. Don't do that to your people. It's bad. All right, getting closer to finishing up here. Listen to your users. Lacey, this section is for you. And so this is the founder of Sony. And he says, oh, we never ask consumers what they want. They don't know what they want. Or we figure out what they need, and we're prepared for them to catch up with us. It's very similar to Steve Jobs, very similar to Henry Ford, some of the more innovative, forward-thinking companies and thinkers. And so often, this is what I find when we're, again, since we're at HIMSS here, talking about implementing technology, asking people, how should this thing work? Well, that's good. I do want your insight and input, but then I'm totally prepared to ignore it. Right? I'm totally prepared to ignore it because it might be that you want me to recreate what you have today because you have muscle memory. And there is something to be said for that. However, recreating the horrible process you have today in our brand spanking new EHR is going to decrease a little bit of the pain of moving, but then it maintains that pain forever because I can't get to the point where I want to get. And so you want to listen to your users. You want to acknowledge that they're there. You want to know that no one has 1.9 children, even though that might be the average user, the average parent. That doesn't exist. And so kind of going into the real world and finding real people is something to do. What Lacey was pointing out is that experts in one domain does not mean anything about a different domain. And so being a world-class neurosurgeon is awesome. But me asking that world-class neurosurgeon how they want the EHR or other workflow to work doesn't make a lot of sense. And the last person that you ever want to ask a question about how something should work is the chief of any department, especially at a big academic center. I like to tell the story the first time that Epic had put out this PEP report, Physician Efficiency Profile. This was years and years ago. They basically ranked every doctor at my hospital system from 1 to whatever, thousands of people, in terms of how efficiently they use the system. The most efficient, by far, was our physician, our surgeon-in-chief, a pediatric cardiothoracic surgeon. And all of us looked at it and immediately started laughing, because this guy has touched the EHR 3 times in his life. And the only 3 times I know that he touched it is with a fellow that was typing in for him. So he had no reason to use it because he had a phalanx of fellows and students and residents around him. And so he would be the last person that I would want to ask, hey, how should this work? Yet that's who we go to often because they're the chief and they're powerful and they're smart and they've been around the longest. But because of that, they're probably the worst. I want a journeyman cardiothoracic surgeon. I want someone who's in the system all the time. If that's not them, then I want their PA who's in the system all the time, putting orders in on their behalf for them to co-sign. That's an appropriate thing to do. So, Lacey, if this is I'm picking on you now because you picked on me. If this is your chief of cardiology, then this is not your real user. And obviously, first of all, started looking for chiefs of cardiology, and I thought that might get me in trouble if I put their picture up here. So I made up a picture, or I had an AI make up a picture. And I'm just fascinated by the fact that there's a chest x-ray that's framed and put on the wall. And I could not get the LLM to take that away. So, and I'm sure people who are much smarter than me know how to do that, but I thought it was hilarious, so I kept it in. Yeah, this is not your end user that you're asking about in terms of how to configure a system. And finally, acknowledging that any technology that we're going to use, any workflows, any setup for how a clinic functions or hospital functions or an OR functions, you have to have a continuous improvement mindset as part of the design process. What does that mean? Whatever you do, this is another one of my famous, I think, or maybe infamous implementation design theories. Hey guys, it doesn't really matter what we do, it's going to be wrong anyway. Often it is, because we can't predict. Oh, well, this is how it worked at the other 3 hospitals, and they loved it. Okay, well, that's a good place to start, but we still have to acknowledge that this 4th hospital might be different. Those were big hospitals. This is a small hospital. They have pharmacists 24/7, 365. This one, we don't have a pharmacist at the weekend. Oh, okay. That's an important fact. And so we're going to have to fix for that because we didn't figure that out. We should have figured that out before, but we didn't figure that out. So how can you have this kind of continuous improvement concept? One, trying to be wrong as infrequently as possible. I think that's a better way of trying to be right all the time. Just trying to make the minimal amount of mistakes, acknowledging that we're going to make mistakes. Keep moving, keep acknowledging and understanding that, hey, we're in healthcare. Sorry, we're in healthcare. Technology is changing very quickly. That's been true for the last 20 years. Oh my God, is it true now? The AI that you're using today is the worst AI that you'll ever use. And by the way, the next better AI is probably going to be next month. Right? Things are changing very quickly. So decisions that we made last year may have been the right decision. They're not the right decision today. That was not the right decision today, and acknowledging that. Same with healthcare. You know, things that when I started practicing medicine were standards, and we've always done it that way. Now we look back and go, ooh, that's probably not a good idea. And can't believe that we ever did that. But we were making the best decision we had. So we're in an industry with two things that change all the time, and yet we expect to get it right most of the time. Unlikely. And then kind of making sure you have that Silicon Valley concept of, hey, we're going to fail, but we're going to do it quickly and cheaply, and we're going to pivot, and we're going to learn from it, and we're going to move on. That's okay. In healthcare, we don't want mistakes, but we can tolerate mistakes that are not causing any serious problems, right? So if we just backed up billing for a few hours because we did something wrong, that's okay. We'll fix it and we'll move on. Patients dying in the emergency department, not okay. So we don't want to go that far. I don't know if anyone's ever seen this. Have you seen this picture? It's kind of a famous picture. I think from 2012. It was in JAMA. It's a great. As I mentioned, I'm a pediatrician. This is a drawing that a child made for her pediatrician of her visit, and you can see that on the right is the mom with the baby, and the artist is in the center, sitting down there. And who is that on the left? That is the doctor. And what is the doctor doing? Not looking at the patient. Right? Not looking at the patient. This is what we get when we're poorly designing workflows. Should we blame the EHR? I don't think the EHR said that you had to put the monitor on a table in the corner of the room. All right? That was not a good decision. Was it a decision, should I blame someone? Probably not, because most of us, when we started, did not design rooms for technology. That was the place we could put the monitor. And there was no option for a laptop because there was no such thing as a laptop that bounced as well as it needs to bounce if it's going to be used in healthcare. So it wasn't really anyone's fault, yet this is what we get when we implement technology in a suboptimal way. Are there ways to design around this? Absolutely. What's the easiest? Making the screen bigger. Making the screen bigger and making a triangle between the monitor, the physician or the nurse who's putting information in, and the patient on the other side of that triangle. They did a study years ago where they asked patients who were in the room, hey, can you estimate for us how much time your doctor spent looking at you, making eye contact with you? And then they also videotaped this, so they knew exactly how much time the physician ended up looking at. And when they had that configuration, that triangle configuration, the opposite of this, guess what? Patients significantly overestimated the amount of time that doctors were making eye contact with them. In fact, they actually appropriately estimated the amount of time if you take looking at the screen with the patient as eye contact time. Pretty amazing. So doing that kind of a simple thing, that design tweak, makes a lot of difference. Hey, ambient scribes, much better. Don't need to do any of this, right, to some extent. So we're moving in the right direction, but this is a design problem that was identified in 2012, and it hasn't been fixed in a lot of places since then. So what can you do now that you understand some of these very basic design ideas? Find the patient, find the clinician, and understand what they think. You can do we talked about kind of understanding the user. I like to just walk around and ask questions. There are more specific scientific ways of talking about this, ethnographic research. I like that. It really means walking around and asking people and seeing what they're doing. Having patients involved in some of your decision making. Again, just like any user, I like the patients to give me their advice. If they're an oncology patient, their advice is going to be very different than a patient who is not a chronic user of the system. So you have to keep that in mind. So having a good, kind of a lot of different patients who can give different perspectives is something very helpful. We can talk about design workshops. A lot of folks have done this, or will bring in a third party, or they'll at least be intentional about it. One thing, and this is a quote that I love, Don Norman is one of the principles of design and human-centered design or user-specific design. And he talks about needing more design doing and less design thinking. It's great to come up with a concept and workshop it out, but if you're not actually making those changes, if you're not actually operationalizing, if you're not going back and making sure that the folks that you designed for are still using the system the way that you thought, it's not good, and you won't have good outcomes. And so I always, whenever people talk about innovation, they talk about innovation a lot, without operationalizing your ideas and then executing them well and making sure that they change and modify as needed, you're not going to get there. And then finally, I'll just kind of go to this. Our final summary is or at least my final summary is be intentional. So think about these 6 things that we talked about. None of it is rocket science, nor is it brain surgery for Dr. Simmons. This is pretty straightforward stuff, but you have to think about it as opposed to just going and doing what you've typically done, which is go and ask the chief of cardiology, does it make sense, right? Pass the sniff test. And by the way, I just want to point out, this is another elevator shot, but I didn't take this picture. Does it make sense? Does this sound like something that our doctors, our nurses, our receptionists, our billing folks will want and will use? And then finally, getting leaders on your side. And so it's so important to, especially from the CEO on down for big changes, so important to have the executives briefed, tell them what they're probably going to hear when they get attacked at the elevator, so that they can respond intelligently to what they're hearing. Because if they just hear the side of the person who's not happy, they might come back to you and say, hey, I need you to make a decision that's contrary to what's probably in everyone's best interest. So I think that is it. I have 5 or 10 minutes to go. I'm happy to take any questions as long as they are not negative about physicians. I'll even take those questions if you. Oh, I've thrown a lot at you. Yes.
So I'll try to make this not about physicians.
Please.
One of the challenges that a lot of us in this room face is teaching our organization how to do this work. And I am so happy to be here with my team today and thinking about, okay, this is great. What do you recommend as fundamentals around teaching an organization? I love how you laid out, like, you've got to get the buy-in, you got to do the design thinking, solve for the right problem. How do you teach people to figure out what the right problem is and work on that? And I don't just mean like one person, but 2,000 or 5,000 people.
First of all, I feel I owe you now $20 as well for asking the right questions. So I think, step one is what is it we're trying to change and why, right? And so, again, we've had this conversation a little bit about innovation. Hey, I want to be innovative. I'm a very innovative person. That's awesome. Why? What problem are you trying to fix? So that's the first issue, is that I'm trying to do something because it involves cool software or some cool piece of hardware, but I'm fixing something that's not broken. So step number one, as I said in one of my slides, first figure out what it is you're trying to fix, and then it's easy to fix it once you figure it out. So I think that's really the most important thing is, hey, if you can't show me specifically what the problem is, then we shouldn't be talking about this, whatever this is. When I was the CMIO at a couple different hospitals, I was kind of well known for getting irritable when doctors came to me and told me what they needed. Oh, I need this order set. And I'm like, yeah, so I don't do what you need. Tell me what the problem is. I can get away with this. I'm not telling you to do that. Tell me what your problem is. And then they would tell me, and I'm like, okay, that's awesome. We could do this other thing. Have you ever heard of this other thing that the EHR does? No, I didn't know about that. I'm like, that's my job, right? Don't come to me with the solution, come to me with a problem. And oftentimes people come with the solution. The solution is what I saw at this really cool conference from this very nice sales rep. And it is cool, and I'm sure that sales rep was very nice, but if I'm not having that problem, why should I engage with this? And if I am having that problem, are there cheaper, faster, easier ways for me to solve the problem? So I don't want to say thinking out of the box, but just intentionally going through and being like, okay, the problem is that we're losing this form all the time, and we need to turn it into an electronic, way of putting it into the EHR. Okay, question. Why do we have the form? That's the first question. Do we still need this information? Is this information we needed in the 80s, but we don't need now, but we collect because we've always had the form? Right? That's just kind of intentionally going back to, okay, we do need this information. All right, where else can we get the information from? Kind of just thinking, like, do we already have this and it's in different places and we can just pull it together? So again, if you go through all of those kind of those ideas, at least if you're just intentionally thinking about it, you're probably going to come to the right answer. And so I don't know who said it, but I love the quote, so I steal it often, that Chief Information Officer, CIO, should really just be Chief Imitation Officer, right? There's solutions that so many people have already thought of, and your job as the CIO or a tech person should try to be not to recreate the wheel, but like, did someone else already solve this problem? I don't need to be innovative when a hospital 2 states over has already figured out how to do this. I can just copy it. That's intentional thinking and trying to go through. So I don't know that it's a good answer, but it's the only answer I have. Kind of just going back to basics again and again. Never come to me with a solution, come to me with a problem, and then let me suggest a solution. And if maybe I get it wrong and you correct me on that, or maybe I got it right, you didn't even know that solution was an option. People love it. Yeah, I was going to give you one other little tidbit, which is the smaller the change, the better many people love it. I've asked many doctors, hey, how's that new cardiology module working out? It cost us $10 million to implement. It's all right, but you fix that typo in that smart text. The second paragraph, I always have to fix it, and that's awesome, so I really want to thank you for that. It's the little pebbles that kill people. It's the boulders that they don't really acknowledge. So again, keeping in your mind that sometimes what we think is a big deal and a big fix is not so much for some of our users. It's just an okay thing. Yes?
I just want to thank you. I'm a health economist in a healthcare system, and we have found millions of dollars associated with these teeny tiny changes. Modifications to order sets, and everything that goes into the EMR has an ROI. It's really important stuff. Thank you.
Yeah, awesome. Millions of dollars with easy changes. So it looks like I'm getting the hook here. Am I getting the hook, or we have time? I don't know if we have any more questions. I'm getting the hook. All right, I'll be around if you want to discuss. 5:30. What time? 5:30.
So as a reminder, Dr. Joseph will be at the networking event that I'm going to keep putting a plug out there for. He'll be signing this book. We'll be there starting at 5:30 with music starting at 6. Thank you.